twins, 100 years old. She's 103 now. So edema is a side effect with calcium channel blockers, and as I mentioned, we try to reduce that side effect. Not caused by fluid overload. A lot of times providers will prescribe furosemide and take them off of thiazide, which is going to reduce blood pressure control. This edema tends to be dependent worse later in the day. So we always consider other etiologies of edema. A lot of times the edema is mild, in which case we recommend reassurance, but it doesn't preclude a switch to another calcium channel blocker, such as nifedipine. So in more complex patients where you do need a third drug to add on, you don't say we can't use calcium channel blockers anymore. A lot of times the edema is mild, requires reassurance, and other times you can just switch to calcium channel blocker. Another thing we do to improve adherence is our blast reminder calls. So patients are late in refills a couple weeks. They get a blast call, HIPAA, okay, it goes to their home phone. We don't know who's going to answer it, saying that if you're a Kaiser member, if you forgot to pick up your prescription, this is a reminder to do so without mentioning names and any private information. And so our internal studies show that these blast calls improve pickups. So the things that we can do to improve adherence are to make the treatment algorithm simple, reduce the pills, reduce the times a day. They take all their pills in the morning after they brush their teeth. We improve physician messaging to improve long-term adherence. We give these reminder calls, and we also try to improve our communication techniques. We try to encourage and do a lot of training for AIDA, acknowledge, introduce, duration, explanation, thank you, introduce. We introduce first and last names to reduce formality, explain what we're doing up front, and always thank you. Thank you for the time to come in. Is there anything else we can help you with? So these messages, this kind of interaction requires training. It improves trust, and trust improves adherence. Lifestyle modifications, I'll just rush through because this is another talk, but evidence-based modifications that we know improve blood pressure control, weight reduction, dietary sodium reduction, physical activity, moderation of alcohol consumption. All this is low doses make a big difference. Weight reduction, 10 pounds makes a difference. Dietary sodium reduction, we don't say avoid sodium, we say, just cut out salty foods that are obvious to you. Another question that we encourage is how many times a week do you eat out of restaurants? And if it's more than once, we try to coach them to make it just once a week. Eat more fruits and vegetables, because the studies show that more than one meal a week in restaurants really increases sodium loading. So that's one very specific question you can ask to prove this. When it comes to alcohol, no more than 1 drink a day for women, 2 drinks a day for men. You don't have to abstain. So it's just, it's a multi-faceted approach. Small changes over time makes a difference, can make it. And the incentive for the patient is that you can reduce a layer of medication if you can improve your lifestyle. So the patients are saying, what can I do? Can I reduce my pills? I said, well, if you can, this is an incentive for that type of patient, which is very important. Scheduled 2 to 4 week follow-up is key, as I mentioned. You have to have them cycled in until they're controlled. Accurate measurement. We had a competition in our medical centers to see if they can come up with the most impressive long blood pressure taking technique. This is the photo that won the competition. So so we talk about device, you know, oh, you gotta use this machine, that machine. And apparently about 80 or 90% is not the machine you use, it's patient positioning. This is from JAMA. Cup too small, unsupported arm, elbow not on the table, patient talking, patient listening, back unsupported, feet on floor, legs crossed, full bladder, foreign blood pressure. So 5 or 10 millimeters is a big difference. And so we have to train our patients, especially now that we're doing more whole blood pressures, you know, how to do that properly. We also have smart shopper checks in our primary care clinic. And we have in-service medical assistants going to primary care clinics unreported, and they ask the MA, can I go in? And the MA accompanies in the room, and there's a checkup for 4 things. The patient's arm bare, is it totally supported at heart level, talking or listening, proper size cuff, just those 4 things. And then we get feedback data to our hypertension champions. And the most difficult thing to correct is talking. People just like to talk when they're doing the blood pressure talking. So talking and listening, you know, or active listening, you know, increases at 5 to 10. So, you know, so what we can do, so in this kind of reporting, there are certain things that are MA specific, you know, not talking or using a bare arm. But there are other things that are more system-based, like arm support at heart level. What if you don't have the proper furniture in the room, you know, to get your elbow at heart level? You need, you know, so that's a system type thing to explore, you know. So anyway, so with this kind of feedback, you can improve accurate blood pressures and accurately, you know, we don't have A1Cs and blood pressures. We just got to do everything we can to get an accurate, competent blood pressure. So we're using more, you know, in the Accord trial and the Sprint trial, they use these automatic office blood pressure machines, which are programmed to wait 5 minutes and then take 3 readings at 1 minute intervals and mean those. So we're starting to use more and more of these. We have 1 or 2 at each of our primary care medical office buildings now. So we're starting to use more of these. Racial and ethnic disparities. There was an article in the New England Journal of Medicine by researchers at Harvard. Nothing to do with Kaiser, but they concluded in stratified analyses of Kaiser and other health plans in the West, significant disparities between black enrollees and white enrollees. The frequency of blood pressure controls were not evident in Kaiser health plans, but there were significant disparities between the 2 groups in other health plans in 2006. So this is important. I mentioned earlier that we may, at the national level, Kaiser, all the national Kaiser people decided that hypertension control and healthcare, we need to embrace disparity and inclusion. So that requires some additional resources. We're proposing equitable care rather than equal care. If there's groups, if there's this disparity that we see in racial groups or ethnicities, additional resources need to be addressed to tackle that problem. And so we have population care reporting at the racial level as well. And our racial reporting is above 90, over 90% now, because when you check in, patients are asked if they feel comfortable identifying their race or ethnicity or so forth, and there are communication techniques to improve that kind of reporting. We look at, you know, it has to be reaffirmed and so forth. But we have about, in our Southern California population for hypertension, we have 90% or better racial reporting. So then we can look at our data and our control rates over time. And these are the reports we look at. We also do this at the national level. Southern California, Northern California, all our 7 different Kaiser plans over 8 time zones are reporting control rates and sharing best practices to reduce disparity. So one of the techniques we use at the population care basis is targeted therapy. For example, in this one survey, 14% of our black patients with uncontrolled hypertension were thiazide naive, and that's our primary drug in the All-Hat study for the pre-specified group of 14,000 African Americans with hypertension, to get them on thiazide. And then 18% of our black patients with uncontrolled hypertension receiving potassium replacement would be good candidates for spironolactone. So we have targeted therapy. And the nice thing about that is that, for lisinopril hydrochlorothiazide, if they're underdosed and uncontrolled, we can identify our black patients and then just stepwise them on a medication that they're already on and do one step. For thiazide naive, it's one step to get them on thiazide-containing medication. So what we do is we have our population care data, which is good. We can target populations and do a one-touch, increase their lisinopril hydrochlorothiazide, get them on thiazide, and then see what that does to blood pressure control. So it's very rational and scientific. We can also do these kind of ad hoc reports with hypertension demographics and utilization. And for example, this is a report, I probably can't read it at the top, it said demographic utilization of African Americans within our administrative system, controlled and uncontrolled. And so we see that of our uncontrolled black hypertension, 3 to 4, 36% are getting 3 to 4 medications, but when we drill down, only 3% are getting spironolactone. So they're getting drugs, but maybe not the right drugs. So this is the kind of information that can generate implementation, targeted implementation practices. So closing disparity, lisinopril hydrochlorothiazide underdose, get them increased. Thiazide naive, get them on thiazide. No spironolactone, address that gap. And so this is one of our service areas, Antelope Valley, that did this targeted approach, and what they did was show that they could target this group, get them on drugs. But it's interesting, you see that little blip going in the wrong direction at the end. That was when one of the patients making phone calls was out on leave for a few months, So, you have to have every step in sync. And there is resource utilization. You have to have people making phone calls, to make the connections. And so all of a sudden there's a little gap there. And so you have to align your resources with your targeted therapies. So targeted interventions, as I mentioned in summary, optimize thiazide or chlorothalidone, use combo drugs, spironolactone 4 drug, lifestyle improvement, particularly salt reduction. I'm not sure I have time, but you mentioned, Sprint and the new recommendations, and I'll just mention that,
We started you a little late, so why don't we give you, how much time would you feel comfortable to get through your slides?
Yeah, so anyway, so I'll just.
We can easily go another 10 minutes.
These are just my summary slides, so I won't make any comments about the new recommendations.
I do think those are important, though. I don't want to skip that.
What's that?
The new recommendations are so important.
Okay.
Yeah. I mean, it's not often that we have one of the nation's top hypertension leaders in the room. We don't want to cut it short because we got started a little late. People were very bollocksed up in traffic.
All right. So basically, Sprint, there are certain practice-changing studies, and there are NIH, NHLBI supported studies that have made huge differences in our treatment plans. You know, going back to the VA studies in the 1960s that showed that blood pressure treatment works, you know, reduces heart attacks and stroke. And those early studies by Ed Fries made a huge difference. HDFP showed step care. SHEP was enormous, systolic hypertension in the elderly program. Before that study in the late 1990s, we were just treating diastolic hypertension. Nobody thought to treat systolic hypertension. So, you know, SHEP came out in the late 1990s and said, wait a second, you know, that's more important, you know, so that changed everything. So, you know, there are very seminal studies over time, and I put Sprint is definitely in that category because they showed that lower is better for targeted groups. So there's SHEP, and then there's the ACCHA hypertension guideline, and what, you know, it's not a very readable guideline. So,
it is. We have a hypertension little pocket card that was created by some of our co-chairs up north for JNC 8. And the group could not come to consensus on how to make a pocket card for the post-Sprint guidelines. So we would love your help with that.
Yeah, so I was on JNC 8, so I like to hear that feedback. But that's a problem with this. So if you look at page 71, it says use of blood pressure lowering medication is recommended for primary prevention for an estimated 10-year ASCVD risk score less than 10% for blood pressure greater than or equal to 140/90. And then they say use of blood pressure lowering medication recommended for secondary prevention of recurrent CVD events and primary prevention for an estimated 10-year risk greater than 10% for BP greater than or equal to 130/80. So, and then, you know, the way AHA is boiled down is 130/80 for everybody. But that's not what it really says, you know? And so,
isn't it if they have certain other comorbidities or they're higher risk?
So that's where you get the Sprint, you know? So Sprint identify, you know, if you've had an MI or a revascularization procedure, peripheral revascularization, carotid enterectomy, you know, those kind of ASCVD indications, you know, then you have a lower systolic goal. And then Sprint says if you have if you have a risk score, a Framingham risk score greater than 15%, that's what they say in Sprint. And then when you look at the HA guideline, they make that 10%. Would they make it, you know, 10%? So it's just, it's kind of a, it's not based on Sprint. It's kind of a, you know, guideline creep a little bit. So,
well, no wonder our group hasn't been able to come to consensus on a pocket card since JNC 8. We haven't been able to come up with a new one because it's so complicated between.
Yeah, so it's the other thing
so
I just mentioned is that.
What's Kaiser doing post-Sprint? Are you changing to the 120/80?
Yeah, so basically, I'll get into that. Let me just do a couple. So JNCA, we identified 5 high-quality diastolic blood pressure control trials. Remember, I told you that before SHEP, World Diastolic Days, and they identified less than 90 as the goal. So that was 5 randomized controlled trials. Hypertension optimal treatment is the only randomized controlled treatment trial to randomize to address 90 versus 80. There was no difference. So, you know, HA came up with 80 based on epidemiologic stuff, and you know, they'll show you the curves. But the randomized controlled trials, which should be our strongest evidence, suggest that diastolic goal less than 90 instead. The other thing is that Sprint eligibility would be, according to a JACC paper, inclusive for about 20% of adults treated for hypertension. The other criticism about Sprint is that in order to get the separation between the 140 and the 120, the protocol called for scaling back. In other words, if the target was under 140 and they were under 135 or under 130, you'd scale back drugs. And that's not what we do in clinical practice. So almost 90% of participants in the less than 140 group received at least one reduction of medication. So in Kaiser, we have data showing that when we achieve greater than 90% control rate, less than 140, our mean systolic blood pressure is 128 for our hypertension population. We don't dial back drugs, when below 135 or 130. So this is a clinical trial that, for purposes of the clinical trial, they had to scale back, but it doesn't represent true clinical practice. So at Kaiser, in answer to your question, the goal is less than 140 over 90 for, the broad population. And that's what HA really said, is their grade 1 evidence. But we do say less than 130 is recommended or strongly considered for the sprint groups. And the sprint groups are the ones I mentioned, plus we have a new K-pair risk formula replacing the Framingham risk score for 10%. That's based on our population and our equation. So is that it? That's what we're doing right now.
So do you mostly target the systolic now, and then the diastolic comes with?
Sorry?
Are you after that top number, mostly the systolic?
Yeah, that's the big driver. The other thing is that as people get older, 50% of people older than 50 or 55 will have hypertension. And hypertension escalates with age. 70% patients 70 and over will have hypertension. But the diastolic pressure, population-wise, with age, peaks at 40 or peaks at 50, 55, then tends to go down. Systolic pressure goes up. So almost all the hypertension that we're developing, that we're recognizing, identifying in older patients is the systolic variety. So we see, due to changes in the vasculature and so forth, we see more of an increase in pulse pressure as people age. So most of the blood pressure we're dealing with is systolic, and that's the most important thing to drive down. So really, when you're driving down systolic pressure, less than 140, less than 130, you don't have to look at the diastolic, it's already low. The issue in younger people tend to have more diastolic hypertension. But systolic is the most important risk predictor. So in summary, key elements of a comprehensive large-scale hypertension control program are a registry, and comprehensive performance metrics, transparent, widely visible, clinic-level feedback, treatment algorithm, single pill combination, medical assistant blood pressure checks. And then it's a culture of quality improvement and accountability. Annual quality care targets, the leads develop goals at the beginning of each year to be achieved that year, so goals are important. Performance reporting on a monthly basis, sharing of best practices, peer meetings, clinical level feedback.
So your second bullet point there was unblinded medical center performance reports. Do the providers and the MAs, are their names
Yeah,
known
they
as
do
to
it
who are the
down.
high performers?
They do it down. So the report is tailored to who's receiving it. So at the medical center level, they're getting an overview. How they're doing and how we can improve, and then they're talking, at a higher level. And then those reports get drilled down to individual physician. And also we have MA-specific reports on how often they take a second blood pressure when the first is elevated. So we can drill down to the MA.
So does Dr. Handler know how Dr. Emmons' scores are and vice
Yeah.
versa? It's totally public across your
Yeah,
group.
that's right, it's something like, you know, they've got at the medical office building meetings that you can see, you know, how you do.
We find that a consistent, important factor for the high performers.
Yeah, that's important, you know, people worry about, oh, some people are gonna feel downtrodden, you know, but that's not our approach. Our approach is, you know, if the improvement is needed, we're not gonna criticize you, we're gonna give you the tools to improve. And and then we have people performing well, that can share, you know, their best practices and how they're accomplishing their goal. So it's team-based care. We're all in the same business of improving patient care, and that's the bottom line.
Well, I'm sure we have a few questions for you, and that was really outstanding.
Joel, I'll speak loud enough. Oh, it's right there, thank you. Joel, you briefly mentioned, you know, getting the home blood pressure with the guy doing the exercise. What is Kaiser's stand on that now? Do you recommend people do their home blood pressure? Do you pay for them to do the blood pressure monitor, et cetera?
Yes, that's where, you know, it's member-centered care now, right? And Hattie's talked about, you're talking about that, and so we do encourage home blood pressures. At the national level, we look at, there are 3 accreditation societies for home blood pressure monitors: the American Association, the British Hypertension Society, and the European Society, and they all have grade A and B, you know, machines. So we look at those ratings and find out which are the highest level machines, and then we negotiate a national contract, you know, with that, and that's the supplier for our Kaiser pharmacy. So we have identified the best machine, and then, you know, that's what we try to make available. Then we have training for patients, you know, and, you know, I mentioned, you know, patient positioning. You know, they think they just turn on the machine and, you know, see what, but they have to know, you know, how to take a proper blood pressure, so there's training. And then what's the frequency, you know, what's the, you know, so we have them take, you know, 2 or 3 blood pressures in the morning before their morning medications, if they're on medications, and then throughout the first blood pressure, do that 2 or 3 times a week in the morning for a couple of weeks in a row. So there's a template. So there's a machine, there's a patient positioning instructions, and then there's a template. And so, you know, if there's a discrepancy between home blood pressures and office blood pressures, well, sometimes automatic office blood pressure is the tiebreaker, and rarely we do 24-hour ambulatories. But I mentioned when I was going through that aided approach, the thank you at the end. Thank you for coming in today. I mean, thank you for coming in today means that they've spent 3 hours, you know, getting to their appointment, waiting, you know, going on, you know, why don't we do a telephone visit, you know, so we can do you know, a telephone visit or a Skype visit, you know, show me your home readings, you're on this medication, increase this. So I think that's a direction we need to pursue.
Dr. Keith Emmons.
Just a follow-up, what's the cost to the patient for the machine?
Cost?
Cost to the patient for the blood pressure machine?
It's about $40, you know, that's another thing, it can't be too expensive. So I think it's $40, $45.
And do you have any assistance?
There's a new online that's a cuff that takes all size arms.
Mm-hmm.
So you don't have to be, you know, specific, so that helps as well. If they do get, you know, a lot of times people would just go to the store and get an arm rod, which is the most common. And so sometimes with those machines, we'll do a validation check in the clinic.
So I've been approached about working on efforts to reduce hypertension in pregnancy. with two goals, trying to reduce preeclampsia and also trying to reduce the